Thank you so much, and thanks to everyone else who's joining this fascinating conference. In particular, thanks to Rupert for letting me come along and share this information. So I guess my background is going to be different to many of yours, in as much as I spend a lot of my time working with people who have developed problems with drugs. And if you'd spoken to me 10 years ago about ketamine, I would have harped on about various risks and harms. And I'm having to reorientate myself, like so many people, to of course accepting that so many things that people use for pleasure, of course, can be used for positive therapeutic benefits. And I want to take you through some of the data that we've collected over the last 5 or 6 years that I hope you will find interesting. So I want to look a little bit around kind of global patterns of ketamine use, focusing on recreational use. And I want to do that because I think it's important for us to kind of understand whether regulators are going to be looking at this information, being fearful of what ketamine may do to people who are using it. I then want to move on to some of the work we looked at, focusing on the acceptability of psychedelics in psychiatry. And then I want to finish looking at some of the work I've done with Rupert and his team on people's experience of self-treating with psychedelics, including ketamine. So Global Drug Survey is an independent research organization. We're basically a network of academics in about 13 different countries. And since 2013, we've collected data from over 900,000 people. The survey is normally translated into at least 10 different languages. It's an online encrypted survey. We don't collect IP addresses, and we get lots of people to take part because we collaborate with big media organizations around the world, like The Guardian, Vice, HuffPost, as well as partners in France and Germany and across Europe. This is a non-probability sample. This is not prevalence data, but it adds to the smorgasbord of data. And the truth is, no single data set or no single methodology is going to capture everything we need to know. It's about triangulating data. And Global Drug Survey is particularly useful for exploring in depth patterns of use of particular drugs, as well as spotting new drug trends. We make sure that our data is often available through our media organizations as a way of promoting public health discussion around drugs. But what we also do is repackage our data into a range of free apps and online tools. So that's our way of saying thank you to the community of people who use drugs, who give up so much of their time every year. And we also publish academic papers on a wide range of topics. I think over the years, we've probably collected data in excess of 250,000 people who use psychedelics. We started focusing on this area in 2016. And since that time, we've collected data on more than 50,000 people who have used ketamine, initially looking at things like ketamine bladder and the risk of dependence, as opposed to therapeutic potential. I guess the first thing to say is that ketamine, like so many psychedelics, has seen an increase in use. So as I said, this is not a prevalent study, but if you look across the last kind of 6 years, there has been a fairly consistent increase in the use of most psychedelics, particularly ketamine, where we can see an almost trebling in use since about 2015. But we can also see increases in use in LSD, magic mushrooms, 2CB, and even less commonly used psychedelics like DMT. Because lots of the people tuning in might be from the UK, I thought I'd just quickly put the UK data that says there's been a massive increase in the last kind of couple of years. There was a bit of a drought in 2015, and globally we saw a little bit of a dip, but the UK has embraced the return of access to ketamine with vengeance. So you might look at this and go, well, that's a bunch of non-representative drug users. Do we see this trend in nationally household representative samples? And actually, the truth is we do. So this is the crime survey in England and Wales. This is a national household survey. And you can see there's been a gradual increase over the last 15 years in people reporting the use of ketamine, particularly in those people aged between 16 and 24. And very similarly to the GDS data, an almost doubling in use over the last 3 years. And I think one of the things that makes ketamine attractive is that it's cheap. And in terms of bang for buck, it's one of the best value for money drugs out there. I guess one of the important things to recognize is that although in the media, what we focus on in terms of drug use is people turning up in A&E and people turning up seeking treatment, the majority of people who use most drugs do so infrequently. And that's certainly the case for ketamine. So this is data from about 10,000 people who had used ketamine in the last year. And you can see about 70% reported use on 10 or less occasions in the last year. And in terms of the amount used, most people are using 0.2, 0.3 grams a day. That they're not figures that, if I look at that, hugely worry me. And it's important because frequency of use is such an incredible predictor of harm. A more robust measure, however, might be looking at the proportion of community users who endorse sufficient criteria on the severity of dependence scale and would be classified as being dependent. And you can see here that when we compare ketamine with a range of other commonly used drugs on the street, such as the synthetic cannabinoids, amphetamines, cannabis, MDMA, cocaine, the rates of ketamine dependence are really low. And I think that should be reassuring. But as the little pop-up graph on the right-hand side shows, if we look at kind of at the rates of dependence among more frequent users, that goes up really quite significantly to above 40%. And here we can see that's the case for all drugs. The best thing we can do for society is basically say to people, if you want to use drugs, don't use them too oftenly, don't use them too frequently. If you don't use drugs that frequently, you don't build up tolerance, your risk of developing dependence is really low. But when we start looking at people using weekly or more, the rates of dependence, even for a drug like ketamine, actually start approaching levels that I think are potentially a cause for concern. Another way you can track whether or not drug use is a concern to people is just say to people, would you like to use less of that drug in the next 12 months? And about 20% of people who use ketamine in the last year say yes. That's obviously far less than for stimulant-based drugs. One of the real metrics we're interested in is the risk of acute harm. And so every year for the last 8 years, we've asked people, have you had to seek emergency medical treatment following the use of different drugs in the last year? And consistently, the safest drug is always magic mushrooms. It's not a drug that's taken very frequently, but you can see even for ketamine, it's about 0.6% of last year users reported seeking emergency medical treatment. And for most of the times, that's self-limiting, it's acute, it's panic attacks, it's cardiovascular stress, it's K cramps. But again, not data that would immediately concern me. We previously looked at work focusing on the risk of ketamine bladder. And this was from a sample of lots of thousands that did suggest that ketamine bladder was a real risk among heavy recreational users, with 1 in 4 reporting at least one symptom, such as dysuria, frequency, hematuria. This work highlighted that most people didn't seek help. Most people, when they did seek help, didn't declare their ketamine use, but the majority of people who stopped using actually seemed to get better. But the biggest risk was frequent use, particularly with alcohol. So as interest has grown in the use of psychedelics, we were interested a couple of years ago to look at just how acceptable psychedelics would be to people as treatment. We had a fairly large section on this, but over 20,000 people filled in a section where we drilled in depth the acceptability of different psychedelics. These 20,000 people had already suggested that they would be open to the idea of taking psychedelics for the treatment of psychiatric conditions. And the way we asked this was we created a hypothetical scenario. Basically, it was about going to a GP with depression or PTSD, but with symptoms that were significantly impairing on your daily functioning. And the GP basically says to the patient, well, there's a range of different treatment options. What would you be interested in? In terms of the people who answered this section, what's important to recognize is 80% of them had had experience of psychedelics, 43% had ever reported being diagnosed with a mental illness, and about 20% were currently in receipt of some sort of psychiatric medication. That's going to become important when we look at the acceptability among different groups. So this was the hypothetical scenario, basically saying, I think you need some sort of medication or treatment, but I'm going to give you a range of options. And they were given this range of options. I don't know how many people in the survey actually read through all of this, but I can tell you we spent ages getting this right. But it's basically describing what the treatment was, where it would be conducted, how long it would take. And people were then asked to make informed decisions about how likely it would be they would accept these different treatments. So there were traditional psychiatric treatments such as antidepressants, there were talking therapies, and we also included mindfulness almost as a control. So across the whole sample, and this is probably about actually 70,000 people, because we asked this as an introductory question, you can see that low dose LSD, talking therapy, high dose LSD, hugely acceptable. In fact, much more acceptable than traditional psychiatric medications. And that's a little bit of a wake-up call to those of us who are psychiatrists. Ketamine, slightly less acceptable than some of the other psychedelics, and I'll come to that in more depth. One of the really important things I learned from this is that people's past experience played a huge role on how acceptable traditional psychiatric medications were versus psychedelics. So you can see acceptability of antidepressant medications were much lower among people who had used psychedelics. So you can see that people who had had a psychedelic history, it was only about 35% said it was very likely or likely that they would accept antidepressants versus well over 50, almost 60% of people with no psychedelic history. Likewise, people who had previously used psychedelics recreationally, almost 80% of them said they would be open to using psychedelics for treatment. But what's interesting is almost 50% of people who had never used psychedelics also said they would be open to using them. And that's actually higher than for traditional psychiatric medications. If you put it all together, basically it came out that LSD and MDMA were the most acceptable medication-based treatments. And because across the board, the most acceptable treatment was talking therapy, it also reminds me just how important psychedelics have been at merging talking therapies and pharmacology. And I think for years, practice really hasn't given us the time or structure to actually do that. But you will notice that actually ketamine, either high dose or low dose, was slightly less acceptable. And I think there is something around a reputational problem that ketamine may have. Maybe that's because of fear of dependence or ketamine bladder, or maybe it just isn't as light and fluffy as psychedelics and hasn't had the same sort of positive press. And I think that's maybe something for those people in the field that we want to start challenging. The other thing that for me that was quite reassuring is that for those people who identified any sort of psychedelic as a primary treatment preference, the reason they wanted to use a psychedelic or dissociative drug was because they wanted to get to the root of their problem and they wanted to work with a trained therapist. It wasn't that they wanted something that was quick and easy, that didn't require reflection and working with a trained professional. And I think that's really reassuring. Last year, however, what we were really interested in is that given the fact that there's been lots of press about these medications, but we know that most people can't access them, we wanted to know whether people had started to try and self-treat their mental health with these drugs, either under supervision or just on their own. And that's the data that I want to present now. So this report came out a couple of months ago, and the psychedelic data was based on a subsample of about 25,000 people who had used LSD and magic mushrooms. The self-treatment section was focused on around 6,000 people. The first thing to say is lots of people who use LSD and psilocybin already seem to be using them for functions other than pure recreational fun. 50% said they were using LSD for enhancing well-being, 13% using it to address a psychiatric condition, 30% to address a specific emotional worry or concern. And that was a very similar figure for people using magic mushrooms. For both groups, about 25% said they had experimented with microdosing in the last year as well. In terms of what psychedelics were people most likely to use to self-treat, top of the list was LSD, followed by MDMA, then magic mushrooms, and quite a lot further down the line was ketamine. So it's not as popular, but certainly we had people who reported using it to self-treat. What were they trying to self-treat? They were trying to self-treat the conditions that are common in society. So most commonly depression, anxiety, relationship problems, trauma, PTSD, and a range of other things that we know there is currently work on exploring the utility of psychedelics. What I want to take a little bit more time to focus on now is to present the work that's largely been done by Rupert and his excellent MSc student, Sophie Gray, who took our data and is producing the first of a series of papers on people's experience of self-treating psychiatric disorders with different psychedelics. So the data that I'm going to present here on ketamine is basically comparing the patterns of use and experiences of just under 7,000 people who were pure recreational ketamine users and about 700 people who identified self-treating with ketamine as the major drug that they had used to try and self-treat. For both groups, we had a majority of male recipients, and about 20% were under the age of 21. But you can see there were really high rates of existing diagnoses. We had about 50% with depression, a slightly smaller percent with with anxiety, and about 20% with ADHD. And the current global drug survey, which has just finished, we've specifically looked at ADHD and people's response to stimulants. There is this other group at the bottom that I'll talk about as well, who were just a group of people who reported never using ketamine for any other reason other than to treat their emotional distress or psychiatric disorder. Because importantly, 80% of the people who said they were using ketamine to self-treat also said they were using ketamine on occasion for recreational purposes. So the first thing to say is people who were using ketamine to self-treat mental illness very often had tried other psychedelics in the last 12 months to address their concern. 40% had used LSD, 36% MDMA, a quarter magic mushrooms, 13% had used DMT. And the vast majority had used psychedelics more widely to improve their emotional health and well-being. As we frequently see, people who tend to use more drugs more frequently tend to use the target drug more frequently. So people who reported having used a large number of different psychedelics to try and self-treat their condition tended to use much more frequently than people who were just using a single psychedelic. As you can see, poly self-treaters were using on 127 days. That is a lot. How did self-treaters, though, compare to recreational use? Well, self-treaters tended to use more frequently and to use more ketamine. Recreational users, 12 times a year, using 0.4 grams on an average occasion. Only about the majority of people not using with alcohol, and that's important. But for people who were self-treating, they were using on average 37 times a year, so once every 10 days, and were using a slightly bigger dose at about 0.5 gram a session. The exclusive medication group, people who only use ketamine for medical reasons, used on average 30 times in the last year and were using about 0.6 of a gram. Interestingly, of this group, 18% reported using intravenously and 10% orally. But these weren't people who were just putting all their eggs in the ketamine basket. They were seeking other therapies as well. In the last 12 months, this group had accessed talking therapies, a third had seen a therapist and were also taking some sort of psychiatric medication, 44% reported taking mindfulness. And interestingly, 72% said they had taken ketamine within 24 hours of their prescribed medication with no significant adverse effects. And that's really important because I think it's what differentiates ketamine particularly from the psychedelics, where the chronic use of SSRIs may actually blunt the therapeutic response. And so then you've got the challenge of maybe having to withdraw long-term antidepressant treatment before embarking on a novel therapy. We don't have to do that with ketamine. We weren't just interested in the dose, but we were interested in the intensity of the experience that people were normally having when they took their ketamine dose. So a third reported having an intense psychedelic experience, dissociative, hallucinatory. A third, a moderate experience, 20% mild, 5% mild or minimal. I'm not quite sure what doses they were taking. But in terms of adverse effects, a third said they had experienced negative consequences in the last 12 months. And not surprisingly, it was people who were taking more ketamine more frequently who were more likely to report negative effects. 42% reported concerns about come down, tolerance, and dependence, and 42% acutely reported mental confusion, memory problems, and racing thoughts. 38% reported feeling disconnected, but I guess you'd kind of expect that. But overall, and remember, this is an unsupervised environment without any guidance, about 50% reported no negatives at all, or they were only very mild. I guess the question that you want to know the answer to is, does self-treatment work? I think broadly speaking, the answer is yes. 56% reported moderate to strong positive change in the overall symptoms of the psychiatric condition they were trying to treat. 65% reported improvement in their depression. We've got, 44% becoming more tolerant to other people, almost 60% reporting increase in understanding of why they feel the way they do. Those kind of more subtle things that we don't often measure in psychiatric treatment trials, I think, are really important. But people reporting reductions in social anxiety, people perhaps reporting positive changes in what's important in life. I think in an uncontrolled environment, although this is all self-report, these things for me were far better than I had expected. People reported the onset of positive effects as quickly as we see in clinical environments, 47% reporting positive effects within 12 hours. For 45%, positive effects lasted for more than a week. 20% positive effects lasting for more than 2 to 4 weeks. In fact, some even reported detectable positive effects after 6 months. And of the 30% reporting negative effects, 43% noticed it within a week, but 80% said those actual effects had disappeared within a week. I think all of this is a really positive effect profile. But people who were self-treating were more likely to say they wanted to use less. And interestingly, more self-treaters sought emergency medical treatment than recreational users. So almost 3 times as many. It's still a relatively low rate at 1.7%. But again, that's perhaps something that we could reduce to a much more acceptable level with better training, education, advice, and monitoring. I just want to finish off talking a little bit about some work we did on a smaller number of people who reported taking psychedelics under supervision. These were people who were trying to address a specific worry or emotional concern. Again, the things they were trying to treat, the things that are common in society. In terms of what drugs were people taking under the supervision of another person, the most commonly used drug was ayahuasca within a ceremonial setting, but also LSD, magic mushrooms. But you can see ketamine was being used under the supervision of another individual in about 6% of cases. And I think when we talk about facilitation and supervision, as far as people not accessing clinical trials are concerned, being supervised by, oh my Lord, I am so sorry. I don't know how to get rid of that. That is dreadful. Oh Lord. There we are. That's one thing I hadn't banked on. I'm back. Apologies about that. For lots of people, their facilitator was their partner or their friend. Now, although that person may know you very well, it's unlikely that they're trained in mental health and to manage things if they went wrong. For me, the really interesting bit is how much care and attention were people giving to screening and non-drug preparatory sessions when they were going off to get drugs under supervision of another person. Actually, it was much higher than I thought. When we looked at this 5 years ago, virtually no one was having screening for mental health, but very few people were having non-drug preparatory sessions. I think as we move forward, we need to make sure that people who are facilitating sessions outside medical settings are doing their homework and making sure we don't have vulnerable people at risk at a time of crisis receiving a drug that actually might make things worse. Saying that, when we asked people overall what the experience was of taking a psychedelic under supervision, it was overwhelmingly positive. 52% saying things were very helpful, they got much better. 34% quite helpful, things got quite a bit better. And amazingly, almost 90% said that if that substance was available within a regulated system, they would take it. So for me, all of that is really positive for the direction that psychiatry is moving on. What do I think it all means? I think that we know that how effective medications are when they're appropriately prescribed is hugely dependent on not just the quality of treatment, but how compliant people are. And for people to be compliant, they have to understand that when they're on Zoom and their phone is connected to their presentation, they need to switch their phone off. Sorry. Acceptability is really important, and acceptability is likely to play a key role. I'm going to switch my phone off because my guess is that person's going to phone back. I'm so sorry, guys. So ketamine is really acceptable to many people, but as I said earlier, I think it has a reputational problem compared to LSD and psilocybin. We want to think about that. Drugs that have a positive benefit after a short space of time are really attractive, But I think the worry for ketamine is that we're looking at frequent redosing, and that compared to other psychedelics, ketamine is going to maybe be a drug that people are taking every week or every 2 weeks. And we know that the risk of dependence and harm is related to frequency of use. We need to look at balancing the benefits and risks. And I think to answer that, we need to understand whether large doses given at a lower frequency is better, more effective, safer than lower doses given more frequently. That might be a way of avoiding the risk of tolerance. And we know that if this was given within a private setting, it may be the more socially, economically disadvantaged groups who may be less likely to be able to afford to continue to take S-ketamine, and maybe more likely then to move to using oral street ketamine more cheaply. I think dependence is a risk. I think it's small, but I think we need to revise how we assess dependence on ketamine in the same way that we do with opioids and cannabis. But basically, the longer we delay access, the more people we're going to have experimenting on their own. Like Rupert and many other people, I think we need to register all new patients. We need to have an open access database. We need to standardize measures when assessing self-treatment. We want to consider maybe having guides for unsupervised use. We need better regulation and training for therapists. And we probably want some early warning detection for those people who are at risk of dependence or bladder problems. The one thing that I've been asked lots of times by people who take psychedelics and advocates is, why do we always have to come along to clinics? You know, why wouldn't we just be able to look after ourselves and pick up our medication? And I guess my question for you is, could we ever let people treat their own mental health and well-being on their own with little or no input from psychiatrists? I don't know what the answer is, but it's something that I'm continually being asked, saying, how valid are psychiatrists using these medications when, you know, you've dismissed them for so many years? I don't know what the answer is. My apologies sincerely, guys, for my phone going off. I'm going to leave it there, and I'm going to stop sharing my screen.